Thank you so much for joining us. So today, implementing extra-genital STD screenings for MSM webinar. We would like to invite our speakers to unmute themselves using #7. So please #7 for the speakers. Sorry, *7. Sorry, *7 for all of our speakers when it's your time to speak. So today we're going to have a webinar. It should be about 75 minutes long. And we're going to have several speakers. We're going to have 3 program sites. We're also going to have the executive director of the National Coalition of STD Directors, as well as a provider from the CDC and the DC Department of Health speaking. So we're going to run through and talk about our webinar etiquette for a moment. So to unmute your phone line, press *7. To remute, *6. Verbal questions, there will be dedicated time for questions. So please wait until the Q&A portion to ask your questions on the phone. Also, please identify yourself when asking a question or providing a comment. Our written questions, participants have the ability to submit written questions during the webinar using the chat function on ReadyTalk. And so today our objectives of this webinar is to review the 2015 STD treatment guidelines and the recommendations for sexually active MSM, men who have sex with men, emphasizing non-genital STD screenings. Also to introduce the possibility of using self-collected specimens for penile, pharyngeal, and rectal chlamydia and gonorrhea testing. The third objective is to discuss the non-genital STD screening experiences and share strategies for self-collection of specimen at 3 program sites. So we have presenters from Alaska, Arizona, and Tennessee. And to lead off, we would like to open up the floor to William Smith, or also known as Bill Smith, the Executive Director of the National Coalition of STD Directors, who is going to share some of his perspectives as well as the organization views from NCSD. And NCSD stands for National Coalition of the STD Directors, which is a partner in the Gay Men's Health Equity Workshop. So, Bill?
Thank you, Stephen. Can you hear me?
Yes.
Okay, great. And Stephen, I don't know if it's just me, but I'm having a blank screen on my webinar, so I just wanted to flag that as I begin talking here. Okay. Well, thank you everyone for joining, and let me thank my colleague Stephen Hicks, who you just heard from, who's our health equity lead at NCSD. And also I want to give thanks to our partners at the National Alliance of State and Territorial AIDS Directors, and in particular Todd Harvey, who really helped us put together this webinar today. As Stephen said, NASDAD and NCSD have been working together over the last several years, and with some heightened intensity over the last couple, through our Gay Men's Health Equity Work Group, which includes members from both NCSD and from NASDAD, and really putting our minds together to brainstorm and to come up with actionable items to address the crisis in gay men's sexual health. Our issue today, I think, is one that's incredibly important, and all of you, I hope, feel similarly, and that's why you've joined the call today. We have evidence, most specifically from San Francisco and New York City, that if we're not screening gay men for pharyngeal and rectal infections for gonorrhea and chlamydia, we're actually missing most active infections. In fact, there are some jurisdictions who really believe that for gay men, those are the 2 sites we should be screening, and perhaps if we have to consider which ones not to screen, that the urethra is even less important. It's clearly this evidence suggests to us that these are incredibly important opportunities for us to intervene and to improve the health of gay men, and to help them think about what risk reduction activities look like, and that includes condoms, other risk reducing activities, and specifically for HIV prevention, really recognizing that someone with a positive rectal infection, for example, is probably one of the highest priority clients we could even think of for pre-exposure prophylaxis. My colleague from CDC, Bryce Furness, is going to be discussing CDC's recommendations on this issue. And I just wanted to highlight that NCSD, NASDAD, and our partners at the National Network of Prevention Training Centers held a convening last year to identify a sexual health standard of care for gay men. And that document is forthcoming, and we're really proud to say that we're going to be strongly recommending that 3-site testing for gay men really should be the normal standard of care, given what we know about these infections in gay men. So please look for that as a forthcoming document from us, and I think will be really incredible, will be a really important tool in advancing the field. Finally, I just wanted to mention that many of you may know that we've got some major issues with laboratories as it relates to extragenital screening. First and foremost is there's no FDA-approved test to actually run extragenital specimens. This is easily overcomable, and a lab can individually validate these specimens on their own. Many have, and I'm just flagging it at this point because if you happen to be on the phone and you are in a jurisdiction where your public or private laboratory seems a little reluctant or unaware of how to go about doing this validation, please reach out. Stephen will put up his email address here, I'm sure, at some point. But we'll make sure, please get in touch with NCSD because we are doing a number of activities that we call lab dating, where we're actually getting one lab to work with another lab to send them specimens and develop protocols for that validation. So we have that technical assistance available here. And also related to this, there's some ongoing issues related to billing sometimes for extragenital screening. So if you're experiencing some of those challenges as well, we certainly hope that you'll get in touch and let NCSD know, and we can provide technical assistance. So again, thank you to all of you being here. Thanks to Stephen and Todd and NASDAD for helping to put this together and for the incredible presentations that you're going to hear today. And with that, I will stop.
Thank you, Bill. We would like to also introduce Dr. Bruce Furness from the CDC as well as the DC Department of Health to talk about the STD treatment guidelines.
Good afternoon. Thanks, Stephen. Can everybody hear me?
Yes.
Okay, cool. Good afternoon to most of us. Good morning to some of us. I just wanted to quickly review. There is national guidance on STD screening for men who have sex with men, and it's probably best spelled out in the 2015 STD treatment guidelines, and I just wanted to review that really quickly. Men who have sex with men are listed as a special population in the guidance, and they recommend screening with the following tests at least annually for all sexually active men who have sex with men, both those that are HIV infected and those that are non-HIV infected. So if they're HIV negative or their status is unknown, if their status is unknown, they need an HIV serology at least annually. If they're negative and the patient himself or their sex partners has had more than one sex partner since the most recent HIV test, they also recommend repeating that negative HIV test. They recommend a syphilis serology, and that's basically to establish whether persons with reactive tests have untreated syphilis, have partially treated syphilis, or are manifesting a slow serological response to appropriate prior therapy, or they could be serofast. And those of you that are familiar with reverse sequence testing know how difficult establishing where patients fall into those three categories can be. They also recommend a test for urethral infection with Neisseria gonorrhea and Chlamydia trachomatis in men who have had insertive intercourse during the preceding year, and that's with or without condom usage. And they actually, this is the one that I think this is the first year where they specifically say that nucleic acid amplification testing is the preferred approach. And then the two that we're going to talk about mostly today, where they also recommend a test for rectal infection with Neisseria gonorrhea and Chlamydia trachomatis in men who have had receptive anal intercourse during the preceding year, either with or without a condom. And again, they specifically state that nucleic acid amplification testing is the preferred assay. And finally, they recommend a test for pharyngeal infection with Neisseria gonorrhea. They don't really recommend testing for Chlamydia trachomatis of the pharynx, but since most of these tests are bundled, we usually get those results anyway. And again, this should be in anybody who had receptive oral intercourse during the preceding year, regardless of condom usage. One of the things that I wanted to highlight about this is they say at least annually for sexually active men who have sex with men, and there are several risk factors that if they're present, these men should be screened more frequently than annually, oftentimes or sometimes as often as 3 months. And some of those risk factors basically are having sex while under the influence of drugs or alcohol, having sex with anonymous partners, having sex with multiple partners, or having sex with partners that fit any of those criteria. Next slide, please, Stephen. So I just wanted to talk quickly about the self-collection of specimens for STD testing. I'm in the Division of STD Prevention at CDC, but I've also been embedded in the Department of Health in Washington, D.C. since 2002, and I've been intimately involved with a gay men's health and wellness clinic at Whitman Walker Health. And basically what ended up happening was at Whitman Walker Health, you could come in for an HIV test at any time. You could come in at 8 in the morning, you could come in at 4 in the afternoon, Monday through Friday, but you could only come in for STD testing Tuesday and Thursday evenings during the Gay Men's Health and Wellness Clinic. So I worked with Rodney Perkins, who was a nurse at the clinic, to establish the self-testing. So anybody who came in during the day for an HIV test, because there were obviously reasons why they were coming in to be HIV tested, and they probably should have gotten more testing than just the HIV test, we allowed them to basically collect pharyngeal specimens, collect rectal specimens, and pee into a cup so that they get screened for gonorrhea and chlamydia, and a phlebotomist would also draw blood for syphilis. So we were able to turn these HIV-only visits into much more comprehensive STD screening, especially for these pseudo-high-risk individuals that were obviously seeking health care in order to get an HIV test. And we have found pharyngeal and rectal infections that is almost as high as those of the men that are coming into the Tuesday and Thursday evening Gay Men's Health and Wellness Clinic. I just throw this slide up. They are 3 different articles as recently as 2013, 2011, 2009. Basically, all these articles show are that self-collection of specimens for STD testing is acceptable. In some instances, it's cost-effective. And in almost all instances where this has been published, basically, the results are as good or better than clinician-collected specimens. Next slide, please. So this is just some instructions from the city clinic on how to collect a pharyngeal swab, and I'm not going to go through it, but this is available. It's from the San Francisco City Clinic if anybody's interested in it. Next slide, please. And this is the same thing from the San Francisco City Clinic, instructions on how to collect a rectal specimen for STD testing. So that's all I'm going to say. I think the meat of what we're going to talk about today are program experiences, and I just want to introduce the 3 speakers. Jessica Harville is an HIV prevention coordinator in Alaska. She will be speaking first, followed by Tom Mickey, who is the STD HIV program manager in Maricopa County, Arizona. And last but definitely not least is Brad Beasley, who is the STD prevention director in Tennessee. Thank you.
So this is Jessica Harville in Alaska. Thank you very much. I'm also here with Donna Cecilia, our STD program coordinator, and Derek Murno, one of our disease intervention specialists who've been pretty involved in this project. Just to get started, I think one of the really interesting things we've been able to do here in Alaska is work to implement extragenital screening interventions in a state that's very large geographically, and that's pretty rural and resource poor. We get really low funding for both HIV prevention and STD prevention. So a lot of the things I'm going to be talking about are activities that can be implemented even if you're not a high incidence jurisdiction with a lot of funding to dedicate. So let's see. Since Alaska is a bit of a mystery for a lot of people, we're not in a little box down southwest of Mexico the way you see in a lot of maps. We are up there north of Canada, and we're really quite large. We're the largest state. We have a rather small population spread across that state, and really the vast majority of our resources for both clinical services and DIS services are based out of Anchorage. The other thing that really impacts our ability to offer services around Alaska is that Alaska doesn't have counties. We have 29 boroughs, city boroughs, municipalities, and census areas that have various health powers. And really, Anchorage is our only city that has a STD clinic in it. The rest of the state is served either by private providers, tribal health providers, or state public health clinics. Kind of the history of extragenital screening in Alaska. You might have seen we tend to be #1 with chlamydia, in the top 5 with gonorrhea. We know that undiagnosed gonorrhea and chlamydia can lead to serious health consequences. And the reason I'm involved as the STD HIV prevention coordinator is we know that untreated, particularly rectal and oropharyngeal STD, can increase the chance of someone acquiring or transmitting HIV. Kind of the history, we have historically done very little extragenital screening prior to 2012, and really until 2012, it wasn't happening in Alaska, similar to the rest of the United States. In 2012 is when we began working with our public health lab and actually got extragenital specimen collection validated. It's kind of the first thing we began doing once extragenital screening was validated at our state public health lab was our DIS began working with people they were seeing to take a complete sexual risk history and screen them appropriately at all sites. So for us, since we don't actually have a clinic here at the State Department of Health, this was a lot of in-office services where we had someone go to the restroom in our office, collect the urine, gave them a little brown bag, and then had them self-collect their rectal swab. We did collect the oral swab. Oral swabs were collected by DAS themselves. Really the biggest thing was this is when we really began talking about the importance of taking a sexual history and identifying risk in order to screen appropriately. Fast forward to 2014, we saw a pretty unprecedented spike of new HIV cases in Alaska, primarily in Anchorage and primarily among MSM. That's when we really began looking at how many of those people were also co-infected with chlamydia or gonorrhea, particularly rectal chlamydia or gonorrhea. We began talking about what we could do as a health department to get people screened and tested. This led to this targeted outreach to men who have sex with men. We had a little bit of HIV prevention funds that we could use to do actual targeted outreach and advertising through platforms like Grindr. We also did a lot of unfunded advertising. We had staff who went onto Craigslist and responded to people and let them know about the increase in HIV, and we also had a simultaneous outbreak of syphilis. Let them know that was happening, and inviting them to come into these targeted Saturday clinics where we had DIS staff and staff from some of our other local agencies doing that, taking a complete sexual history and screening appropriately. So we had 52 people attend all the events. I know compared to LA or New York, that's not a whole lot, but for Anchorage, it was a pretty spectacular turnout. Of those 52 people, 33% were positive for chlamydia, gonorrhea, or both. And this was the part that really stood out for us. 71% of the people who tested positive were negative on their urinalysis, but positive either rectally or oropharyngeally. That really showed us that if we were doing urine-only screening in this population, we would have missed 71% of infection. So once we saw the success of this and we had some actual Alaska-specific data to share with our providers, we began talking about what we could do next to get the word out. Like I said, we have a pretty small footprint here at the health department in terms of the actual services we provide. So we began talking about how we could let our clinical providers in the rest of Anchorage, in the rest of the state, know about the importance of screening extragenitally. This is when our DIS, like Derek there, began working with the providers that they were interacting with in the course of their investigations to not just talk about the particular patient they were working with, but sending them this general educational packet either via mail or via email, that talked about extra-genital screening, that talked about prep for HIV prevention, and talked about routine HIV screening. This began really, with very little additional resource, getting the word out to our providers around the state that they really needed to be screening their patients for extra-genitally as appropriate. So that's kind of how we started off. And then we thought, all right, it's real easy to ignore an email or to disregard a piece of paper you get in the mail. It's a lot harder to avoid someone if they're there face-to-face. So we started doing targeted provider outreach trainings. And these took place primarily in Anchorage because that really is where the bulk of our disease burden is for HIV and syphilis. But we also began taking the show on the road, so to speak. So as staff were traveling to other parts of the state, we reached out and said, all right, we're going to be in this area doing a disease investigation. We're going to be in this part of the state working with clinicians on a particular technical assistance issue. While we're there, we're going to reach out to private healthcare facilities. We're going to reach out to Planned Parenthood. We're going to reach out to the jails and ask to meet with their clinicians and talk to them about the importance of extra-genital screening, share that local state-specific information, because I think a lot of rural states probably understand the sentiment that a lot of local providers have that, you see all those reports come out from the big cities, that doesn't necessarily mean the same thing's happening in our service area. Well, we knew it was. We also really tried to provide technical assistance beyond the in-person training. So not just educating the providers, but inviting laboratorians to attend. So we could talk about, all right, how can they submit those extra-genital specimens to the lab? How will the lab process them? Asking the people who are involved in their EMRs to come in to say, all right, how can we make it easier for the provider to actually order that extra-genital specimen collection on the EMR and submit it to the lab? This was really well received. We were kind of concerned because it's always a little iffy when the health department shows up and says, hey, you guys should be doing this. One more priority. But I've got to say we had one provider in the Kenai area of Alaska where after we sat down and spoke with them, the front desk staff began talking with the clinicians about who they needed to call back in, who they'd seen earlier that week, and have rescreened. So people were really receptive of this. I think a lot of clinicians, a lot of staff just don't know how important it is to take that complete sexual history and screen appropriately. Kind of the last thing we did as a part of this project was to actually take a look at our lab data to see kind of, all right, we had this small sample from that targeted MSM screening event, but looking at the bigger picture, is this important to the health of Alaskans? So we took a look at our 2014 specimen that were submitted to the Alaska State Public Health Lab that provides lab services for most of the private, public facilities here in Alaska, including our state Department of Public Health and our public health nursing facilities. So we had a total of 2,804 positive specimens for GC, CT, or both. And of those, about 473 or 17% were in patients who had been screened at more than one anatomic site. About 72% of the specimens that were submitted from more than one anatomic site were males, but we did have some females also. So this was pretty impressive. So of the 473 patients who received that concurrent testing, urogenital-only screening, so urine-only screening, would have failed to detect about 27% of the chlamydia infections and 32% of the gonorrhea infections. And keep in mind, this wasn't just looking at particular men who have sex with men or people with particular risk factors. This was looking at the entire population submitted to that state lab. With the lab data, we couldn't really break down the demographics or risk factors. And really, even in women, about 8% of infection would have been missed by urine-only screening. This is really showing that when we talk about extragenital screening, we're not just talking about men who have sex with men, but we need to talk about taking that risk history, sexual risk history, and screening appropriately. So these were the recommendations that we came up with to share with our providers. One, we wanted to update providers about the importance of taking that sexual risk history and screening appropriately. We also found it was really important to educate MSM on the importance of screening extragenitally, regardless of condom use. I think as Derek and the rest of our DIS worked with MSM, a lot of them didn't realize that they could get chlamydia, gonorrhea, STDs orally or rectally. So there's kind of two sides of that coin. We want to be working with providers. We also want to be working at people who are at higher risk of acquiring disease. And then finally, the last bit was touched on early in this presentation, but when we were working with providers, we really wanted to make sure they knew what their specimen requirements their lab had. So for some facilities who are using the larger reference labs like Quest, like LabCorp, pretty straightforward. For some of our hospitals in rural areas who have an on-site lab that might be referring to other facilities around Alaska, it was a bit of just providing technical assistance and guidance on what they should be asking and how they should be working with their labs to make sure those specimens can be submitted appropriately. So I put a question slide up. It's actually not questions. I think we're going to do questions at the end of the presentation. But there's my contact information and the contact information of Donna. And we will both be available at the end of all three presentations for questions. Thank you.
Thank you, Jessica. Now we will have Tom from Arizona tell us about his program. And *7 to unmute your line. Tom, to unmute your line, *7, please. Tom?
Stephen, this is Bill. Maybe you just want to let Brad go.
Yeah. Okay. So in the meanwhile, we will pass it on to Brad Beasley, who is the STD HIV Prevention Manager of Tennessee, and then we will try to return back to Tom. So Brad?
Oh, yeah, I'm here. Thank you. Good afternoon, and I guess still morning, yes. Yes, I'm Brad Beasley with the Tennessee Department of Health, the STD Prevention Director. And so I'll kind of give you an idea of what we have been doing here in Tennessee. I guess kind of as a setup, our state, we have 95 counties in our state divided into 13 public health regions. Each public health region has its own leadership structure. 6 of those regions are metropolitan regions that operate autonomously from the Tennessee Department of Health, and the other 7 multi-county rural regions are an arm of the Tennessee Department of Health. So this is significant in rolling out a change in the protocols and implementing something new, because there are then several different layers of buy-in and leadership that we have to go through in order to affect the change. So I just kind of wanted to put that up there with this map and give you an idea of how that's laid out. Also, it's important to note that Tennessee Department of Health covers the cost of the test and of the lab processing for the entire state, and the intent behind that is so that anybody can walk into any health department, county health department in the state, and get a STD test, free HIV test, syphilis test, and gonorrhea and chlamydia test. So I'm kind of proud of our state for doing that. So with that kind of in mind, when we started rolling out extra-genital testing, back in early 2014, in trying to do some cross-cutting between our program and the statewide nursing program, I started having conversations with the nursing leadership on how to put into play extra-genital testing and 3-compartment testing. So what developed out of that was this interview refresher training that you see on the first bullet there, and that is designed to do a couple of things. Number one, because like a lot of places, the DIS in the rural counties, can't be, if you've got 1 or 2 DIS in a region and there's 14 counties, they can't be everywhere they need to be at once. So there's a really important relationship between the county nursing staff that are talking to the patients and the DIS, and a relationship where they can mutually help each other. So the interview refresher training was designed to bolster and improve the relationship between nurses, the public health nurses, and the DIS. But it was also intended to expand the public health nurses and their comfort level of asking difficult questions regarding sexuality and sexual activity and behavior. If you look at Tennessee, it's about a 9-hour drive east to west across Tennessee, and if you're moving east from the west, as you cross the state, the demographics of the state really flip-flop. The west part of the state is a little bit more, or a little bit less conservative than the central part of the state, which is less conservative than the eastern part of the state, which is really conservative. And within that, there are dynamics within the smaller communities where it could be difficult for a one nurse health department provider to ask really probing questions of somebody in the community. So the training was developed around that, and I think it's been met with a pretty good bit of success. Also in 2014, we validated our oral and rectal GenProbe swabs through the Tennessee State Lab System. That had already been actually happening for a few years before that, but we did a concerted effort to match and walk hand in hand with this interview refresher training. We also adapted the nursing protocol, the statewide nursing protocol, to include 3-compartment testing. Prior to the change, it was there as a tool, but it really wasn't presented as a standard of care. It was more like an option if the nurse thought that it was necessary. So in my discussions with the nursing leadership, we tried to remove or make as objective a conversation that the nurse could have with the patient that would allow her or him more freedom to do 3-compartment testing. So we're not really doing self-collected specimens yet. Rather, at least in the clinical settings, the nurses are doing it rather than letting the patient doing it. So in the protocol, we restructured the protocol to reflect it as a standard of care. The December the 1st, 2014 was when I did the first presentation to the rural region, and that went really well. It really surprised me because I went out there with a preconceived notion that the older public health nurses were the ones that were going to have a difficult time talking about, gay sex and asking those kinds of questions, and the younger nurses were all going to be out there to save the world. And it was really quite the opposite, and I was kind of surprised by that, pleasantly so. And we had some really good conversation around it. In 2015, I did 2 more rural regions and 1 of the metros. And the 6 metros here in Tennessee all have dedicated STD clinics, so they're structured a little bit differently than the rural regions that are general clinics that do everything from TB to STD to family planning and lice head checks and all of that good stuff. The refresher training for the public health nurses, and this is just for the nurses. This is designed for the frontline public health nurses in their interactions with their patients and their clients. It's a 3-hour session. The first hour are photographs of STDs. We kind of take that for granted sometimes, but in some of the rural areas, there are public nurses out there that have never seen a chlamydia drip or a gonorrhea drip or a primary syphilis lesion. So we go through a series of photos that I've been using for a long time. In the second hour, it's a discussion, and we cover several things. What's already been noted here, the importance of taking a complete sexual history, particularly managing personal values versus public health values, asking difficult questions around sexual activities, particularly with MSM, the roles of the DIS. We review the priority populations that we've already mentioned. We talk about interview skills and open-ended questions and things the nurses can do and how they present themselves to the patients and what their body language says. And then we talk about client-centered counseling. So it's more of a dialogue between the nurse and the patient rather than the nurse saying, I'm the nurse, this is what you need to do. It's trying to get buy-in from the patient to articulate some of their own risk behaviors and then articulate some harm reduction method that they could do before their next visit. So we really cover a lot in that second hour. So far, our conversations have really been interesting around the personal values versus the public health values. That's where a lot of conflict has come in, especially in the rural areas where the nurses may have a problem with an MSM, but how they see themselves presenting to it. In the third hour, then we do role playing, and that's also been pretty interesting because I hand out the scenarios. So they divide off. We have a provider and a patient, and the provider has to do a risk assessment, conduct some type of harm reduction, and get the patient to articulate some type of harm reduction, and then we report out and discuss all of it. And that's been kind of interesting because I've had some providers that have had a hard time saying the word homosexual or MSM or things like that. So it's been a learning ground all around. So how it's going so far, it's been a slow rollout because I'm with the central office. I have to be invited to the regions. So I've done 4 of the 7 rural regions to date and 1 metro. There are some significant logistics behind it because getting all of the public health nurses in from the rural counties and then being away from the clinic is a difficult task. So there's really a lot of logistics behind that. Data collection to this point has been challenging. Statewide, Tennessee uses the PTBMIS database, which it's been around so long I can't even remember, but it is an old DOS-based system that in Tennessee was originally set up where STD and HIV were siloed. So if somebody came in, if an MSM came into an STD clinic but was previously positive and didn't get an HIV test, there was no risk data collected for them, for that MSM to get a gonorrhea or chlamydia test. So over the last year and a half, we've worked on combining our risk screens, our supplemental risk screens, so that no matter who comes into or what they come into a clinic for an STD test, risk data has to be collected. That has been challenging because a lot of the rural nurses are like, well, you know, if a woman is coming in, you know, for a pregnancy test, why? And we do a gen probe for that as part of our protocol. Why do we need to get her risk? Because she's pregnant. She's having sex with her husband. And I'm like, well, yeah, maybe she's having sex with 2 or 3 other people too. So doing that system change and changing that mindset has definitely been a work in progress. And I just mentioned, you know, interesting responses from folks across the state moving west to east. We've seen our best response with collection, I think, in the western part of the state, where in the rural areas they are implementing the 3-compartment testing a lot more readily. I don't have information or data on that yet because we completed our PTBMIS risk assessment screen melding back, and it went live last June 1st. So it's going to be another week or 2 before I start looking at that data. And then I've got my next presentation is scheduled for East Tennessee in May, and that's going to be really interesting because East Tennessee is a very conservative part of the state, and I'm looking forward to that. That's all I'll have to say. And I think I've kind of blown through my slides very quickly, but I think anecdotally, there are a couple of counties that are doing some 3-compartment testing in non-clinical settings. Although I haven't had any discussions about that yet, they're just kind of sticking their toe in the water. So this is fairly new for us here in Tennessee, and we're starting to coalesce and pull it together so we can look and see what we're actually doing. And I think that I'm going to end with that.
Well, thank you, Brad. Thank you so much. So we're going to try to get Tom back on the line. So, Tom, can you please to unmute yourself, *7. Let's see if that works. And thank you all for your patience with our technical difficulties. *7.
Hello, can you hear me?
Yes, Tom. Hi.
Goodness. Sorry. That's our problem on this end, I think. I apologize. So, I'm Tom Mickey. I'm the STD HIV Program Manager here in Maricopa County. Maricopa County is actually the Phoenix metropolitan area, and county of about 4.1 million people and 9,224 square miles. So it's a very large county, both population and geographically. A lot of miles, and it's a large metropolitan area. The first couple of slides are just going over our cases of chlamydia and gonorrhea to show that we've had kind of a long-term issue with high frequency of chlamydia and gonorrhea. You can see the chlamydia slides are and that the cases are going up rather gradually, but continuing to rise. 1996, we had over 6,300 cases, and by last year, we had over 20,000 cases. We were number 4 nationally in the ranking of counties and jurisdictions, local jurisdictions. for 2014. So we have a very high case rate. And the thing that we found when we checked with providers in the city and the county was that most of them were not doing rectal testing. In fact, very few were. When we surveyed major HIV providers in the county, only 3 screened, and that was one private provider, Indian Health Services, Phoenix Indian Medical Center here, and the STD clinic downstairs. We have historically done a culture test, a gonorrhea culture test, but once we started doing NAT testing, we saw an opportunity to address the high number of cases. You can see on this slide that with gonorrhea, we saw a real outbreak beginning in 2011. Our numbers had been rather similar to a bell curve up until that point, going up for a year or two and then going back down. And we saw that the decrease pretty dramatically between 2008 and 2010. But then we saw a significant increase. If we look at the reporting data for the state, most of that is urethral because we don't have a lot of testing done, either pharyngeal or rectal testing. So that's been a real issue for us. So what we decided to do was take a look at our case rate within the clinic since we'd started NAT testing, which started in 2011, and this sample goes through 2013. And you can see just a really high positivity rate. We had about 19 cases, 19% of the positives were gonorrhea, and about 12.2 were chlamydia, and the other 6.4% of the positives were both. So there wasn't a lot of dual infection, which would indicate that we weren't catching the chlamydia when we were doing just a gonorrhea culture test. So our plan then was with this new NAT testing that we'd start doing self-collected testing. So beginning in 2013, we began to use the NAT test. And at first, the NAT testing was done through the clinician. But then we got the NAT test validated for self-collection, primarily for community outreach originally, but the medical director decided to also include self-collected testing in the clinic. So since that time, all our rectal gonorrhea testing has been self-collected, both in the clinic and at outside venues. Now, one of the issues Maricopa County has is we only have one STD clinic in the county. So a county that size, both population and geographically, that can be a challenge. So we work on doing community outreach where we offer testing. The CDIs go out, and our CDIs are what we call DIS, communicable disease investigators, go out and perform community outreach, at times with a clinician. Pharyngeal testing is done by the clinician. When we first started doing rectal testing, we decided that we'd continue to have the clinician do it, but so that limits our ability to do it outside of the clinic setting. Then you could see on the previous slide that we had approximately a 23% case rate with chlamydia over that time period, 22.3% and 23.6% so far this year. But with gonorrhea, we've got an even higher positivity rate, from 29.7% to 23%. And as with both, you saw an increase in testing each year. So we are at least testing more people, but we have an alarmingly high positivity rate. And then with community partners, these are providers who we've developed relationships with that we pay for the testing and treatment, and they offer the testing at a low cost or free. We currently have two, a private medical provider in Central Phoenix, Fit Healthcare Clinic. They have told us when we've talked to them about the number tested that they don't always remember with patients that are at risk for non-urethral gonorrhea and chlamydia. They don't always remember to test them. But Southwest Center, which is a community-based organization, offers everyone screening for rectal and oral testing. And they have a much higher positivity rate. Or not the rate, they test a lot more people, but their rate goes down. And then the next slide reviews our community outreach, which is where we go out into the community. We offer testing at different locations. As you can see, I broke it down by the type of business or location. Southwest Center, we were doing testing there until the community partnership began during this time period. So we would go there twice a week and offer testing, and had about a 15% chlamydia case rate and a 9% gonorrhea case rate. Extended hours is our STD clinic outreach, where two nights during the month we have extended hours in the clinic, and we do testing in the lobby and use the restroom in the lobby to offer rectal testing for men at risk. And then we do testing at one of the two bathhouses here in Phoenix, where we offer testing. We don't have a high yield out of that site as far as testing overall. We get between 5 and 10 people typically, and it's still in the early processes. Within probably about 6 months of us offering rectal testing, but we'd like to see those numbers go up. And then the last two groups, we've only done a couple of outreaches at local universities and colleges, and one gay bar has allowed us to do testing. Overall, though, still a rather significant case rate at 12.8% chlamydia and 8.5% gonorrhea. Then, in order to promote our services, we have a rather all-inclusive ad campaign where we try to reach all the venues of trying to get the word out about our services here primarily, and also trying to let people know about symptomology, their risk, and ways that they can get recognize those and get tested and treated. The campaign over the time period between 2013 and 2016 has had actually a couple of campaigns. The Risk is Not Knowing and the Check Yourself After, which is the current campaign, using One Night Stand, which there's the ad on the far left is a pretty good picture of him that you can see. But you can see that we try to target MSM and young adults and underserved communities. So we're looking to try to target those populations, pick outreaches in areas where we can reach them, and offer the testing there. And much of the advertisement focuses on the website because we have a page that gives them the opportunity to choose low-cost testing sites, which a couple of them are now offering rectal testing, and gives them our calendar and schedule of events so that they can know where to go to get our free community outreach testing. And then, as I mentioned earlier, the symptom recognition and awareness of risk. The challenges we encountered: we don't offer the rectal test for females. The self-collected rectal test hasn't been validated by our lab downstairs. We have a lab here at the Public Health Department in Maricopa County, and they're the ones that provide our testing. We haven't had that validated yet, but one reason we didn't do that when we validated male testing was that we had a significant rate, about 13% among males for the rectal testing, but only a 0.59 case rate with female testing. So the low testing rate caused us to hesitate doing that. The screening process, because it's a specific population, males at risk for rectal infection, we have had to set up our outreaches where we can have some privacy for the gay men who we offer the testing to, in order to be able to give them the necessary paperwork and explain the test to them. So that does make it a bit of a screening process in offering the test. And that also leads to a confidentiality issue, just with people waiting in line and quite often kind of crowding the table. Appropriate space and area for collection. Because we have multiple tests on our outreaches. We do both blood draws for syphilis and HIV, and we do urine testing, and then we also offer the rectal test to those that are at risk. We need space for them to collect the samples, and we also need space for confidentiality when they register and we go over the testing that we're going to be doing. And because of the urine test and the rectal self-collection, we have to have a restroom with stalls. The last one, the concern of owners about social perception of venue as a diseased business. That's been an issue for us for outreach just overall. Some are uncomfortable with us doing outreach at their site, whether it involves rectal testing or not, simply because they feel as though if we do, it will make them look as though there is disease present there, and that's why we're doing testing, and they don't want to be associated with that. So that's been an issue in getting in to do any testing of any kind at multiple of our sites. Then the next page just goes over the process at an outreach. The form, which is Form A, is given at registration with the question on there. It's hard to see because the form was rather small, but there is a question on there about whether a rectal test would be necessary. Registered using the Form A, and then directed to the chlamydia and gonorrhea table. They're given a urine cup and or a rectal kit, depending on how they answer the question, and at that time they're also given a self-collected rectal test instruction form. That's basically the same form that was on the earlier presentation. Then they're directed to the restroom where they do the sample collection, and they bring it back to the table for submission. These words got all mixed, jumbled up on several of these slides. some of our goals for expansion of the program would be to increase the number of community partners performing the test. We'd like to develop more relationships with CBOs for high-risk populations so we can offer the test with a broader population set. With our community partnership with Southwest Center, we're seeing a lot of people. They test between 450 and 500 people a month, so it's been very productive. And we'd like to develop relationships with other CBOs. I think there's a comfort level with them that they may not have with coming to our clinic. So it's a way to get people tested who might not otherwise be tested. And then also we'd like to expand the number of private medical providers, particularly if we could get some outside of the central Phoenix area. Phoenix is a very large area in just geographically speaking. So if we could get more providers in the outlying suburbs, that would help us reach out to more people in the county. We also like to expand community outreach setting testing sites. There are currently only 2 gay bars and 1 bathhouse that we do outreach testing at. But only one of those 2 have given us permission to do self-collected rectal testing. And you can see that there are a high number of gay bars and clubs in Maricopa County and 2 bathhouses. So we'd like to also get into the 2nd bathhouse. Add additional sites being named in interviews. And these have been named for a while too, so the trick has been not so much the rectal testing as it is just to been able to get access to those facilities. Adult bookstores, parks, gyms, and sites named on a couple of websites that have been named us in case investigation. And then we're also in the process of reaching out to LGBT organizations in the Maricopa County. And largely there, what we'd like to do is work with the organizations to offer testing events with them at planned events, see if they'd be willing to let us do all the testing that we're capable of. And then, as I said earlier, we'd also like to start doing self-collected oral tests. Now, we need to get that validated, which has been a bit of a hold-up, but once we can do that, then I think it's something I'd like to see us do. We don't necessarily need to do it in the clinic, however, that's certainly something we could do, but we need to do it at outreaches. There are outreach events where we have a clinician go, and they can do the self-collected oral, and or the oral, and then have the patient do the self-collected rectal, or they can do it themselves. But it's very limiting on how often we can have that done. So that's another goal, is to try to expand our testing. So I feel as though we're still in the early stages of developing this. It's a process, and what I'd like to do is expand the opportunities to do it, but also expand the testing itself. To get a better idea of just how much infection we're seeing in the county. With these rates being so high, we think we have a lot, and because the testing simply wasn't being done that much prior, it's one thing that's leading, I think, significantly to our case rate numbers. So that's basically the presentation I had.
Well, thank you so much, Tom, and thank you all for your patience with our technical difficulties. So we have a few questions. So we're going to first we're going to have some questions from our chat. So we have a question from Myra Barber. Is it okay to perform a pharyngeal or rectal culture instead of a NAT test for MSM patients?
This is Bryce in DC. Yeah, you can do that if you don't have nucleic acid amplification testing available. but realizing that the chain of wherever you're collecting the specimen to when it gets to the lab, it's very difficult to keep it in the right temperature and the CO2 concentration. But yes, before we had nucleic acid amplification testing of extragenital sites, the culture was the test of choice for those places.
Thank you. Next question comes from Brandon Culliffe. I'm sorry if I pronounced your name wrong. I apologize. When clients are testing with urine or rectally, do you give them both collection methods at the same time, or have them do one or then the other? I'm sorry.
This is Jessica in Alaska. We give them both at the same time and just give them their little collection cup, their brown paper bag, the Optima and instructions, and send them to the restroom.
Thank you. Our next question, why can't the FDA approve rectal and pharyngeal swabs?
Hey, this is Bill. Can you hear me?
Yes.
Well, I might just be able to shed some light. So first, it's terribly, terribly, terribly expensive for them to undertake that process individually. And what I would say is we haven't proven, frankly, to them yet as, as private companies that there's enough of a market here for them to actually make that investment. So there are lots of discussions with those companies from NCSD and from many others who are getting them to understand the need. But obviously, the more uptake there is in the practice, the more we can show them that there's a market for it. And then finally, there are two efforts underway working with all of the companies, or at least the dominant 4 or 5 companies who are engaged in the NATS platform for CT and GC testing, to approach the FDA as a group and have the FDA consider their application for validation. And I'm told that those discussions are going well, and that maybe the group approach will work, and we'll just have to keep a pulse on that. But right now it is really about the company seeing a return on investment for going through that 510K process for validation.
Thank you, Bill. And so as a follow-up question about the culture versus the NAT question, what is a proper temperature for cultures to be kept?
I do not know that off the top of my head, but the lab that provides the agar plates or the chocolate agar plates that you plate it on should tell you exactly the CO2 concentration, the temperature windows that you should keep it in.
Thank you. Our next question, our health department lab performed the validation work, but the pathologist refused to sign since it wasn't FDA cleared. Any ideas for how we can clear this hurdle?
Stephen, this is Bill. I would just say whoever that is, please email Stephen at shicks@ncsddc.org, and we're more than happy to work with you and see what we might be able to do.
Okay. Thank you. Thank you, Bill. And so the next question comes, I didn't hear any references to penile swabs. Any of the presenters' agencies use them? Also, are any of you aware of data on accuracy of penile swabs versus urine analysis?
So this is Brad from Tennessee. In our nursing protocol, the urine test is the preferred test, but if the patient can't void or is having difficulty urinating, then we default to the swabs. And I don't recall the data, but I think the accuracy of the data of the swabs versus the urine is they're very similar. In some cases, I believe I've read that the urinalysis was a little bit more sensitive than the swab was.
Thank you, Brad. And our
this
next
is Grace in DC. I just wanted to second what Brad said. Basically, originally we were swabbing all symptomatic patients because some of the initial data that came out said that urethral swabs were better than urine tests in symptomatic individuals. But the more data we've collected, the more it seems that urine and urethral, even in symptomatic, are the same.
Thank you. And our next question, where can I find resources used for interviewing refreshers for nurses? I would love for my nurses to go through this training.
Yeah, this is Brad. So the person that asked that question, if you would email Stephen at NCSD with your information, I can share with you what I developed here and what I've been using, and be glad to share that with you.
Sure thing. Thank you, Brad. Do we have any questions online? Press star 7 to unmute. Press 6 to remute. And we will also have this webinar is recorded, so we will have this available for you. And we will also have the slides available on the NCSD website, which is www.ncsddc.org. Once again, if you have any questions, especially around technical assistance or capacity building, feel free to email me. My name is Stephen Hicks, and that is shicks@ncsddc.org. And we should have this posted probably within the next week. So our next question comes, do organizations have to be CLIA waived for client-collected samples?
This is Bryce in DC. I think that's a pretty gray area, and I know that we don't really let our labs know whether they are clinician-collected or self-collected to avoid that particular issue.
Thank you.
I have a question if there's time.
Sure.
This is Tim McCormick with the Hawaii Health Department. First, I want to say thank you for the very interesting presentations. And beyond thinking of things like PrEP for patients with a positive STD test, I think programs should be encouraged to include assessment of current engagement in HIV care for any HIV-positive individuals who are accessing STD screening outside of an HIV care setting, really regardless of their test result. I think it can be an important opportunity to potentially re-engage HIV-positive individuals who've fallen out of HIV care. So my question is, do any of the presenters' programs include that type of assessment? And if so, do they have any data to share on HIV-positive individuals seeking STD services, how many out of care, any re-engagement efforts? Thanks.
So this is Brad here in Tennessee. We are doing re-engagement efforts, although I can't say that we have really rolled it into our 3-compartment testing that we're doing across the state. In our metro areas, we're a integrated program. So in the metro counties, HIV and STD testing is all in one clinic. So the assessment for access to care or linkage to care kind of goes hand in hand. In the rural counties, we're just starting to develop that. So when the nurse is talking with somebody, if they're always going to be identified if they're a previous positive, but we're just starting to stick our toe in the water about getting the nurses to engage that patient's current level of care where they're being seen, and start looking at that. So we're just kind of starting to pull all that together.
Thank you, Brad. And also a follow-up question to the previous CLIA waived question. So we are a CLIA waived AIDS service organization. Do we have to undergo any additional licensure to start oral or rectal collections that we would subsequently submit to a lab or processing?
It's up to the lab, basically. Most of the major commercial labs have validated this and are able to run specimens for pharyngeal and rectal. The Southeast STD Clinic uses the Centers for Disease Detection in Texas, and they do it for us. Whitman Walker Health uses LabCorp, and they do it for them. But regardless of your CLIA waiving, it's the lab that's going to run the nucleic acid amplification test, and whether or not they are validated to do it.
Thank you. And so any other last questions?
Hi, this is Debbie Diamond, Alexandria Health Department. Can you hear me?
Yes.
Okay. We're setting up as a health department collaboration with Nova Salud, our outreach organization, reaching a lot of high-risk individuals in outreach settings. One thing within the Commonwealth of Virginia that I understand is, as a non-medical organization, they aren't able to do testing without having some affiliation with a physician who, quote-unquote, orders the test and then can review and treat the patient. So we as a health department are going to be the people ordering the test, receiving results, and then we're tying them into our Rainbow Tuesdays clinic in order to be able to provide treatment if anyone tests positive. That's just our experience here in Virginia, that the outreach organizations aren't able to test without a physician to order and a place to receive the results.
So this is Brad from Tennessee, what I might suggest is the previous CLIA waived AIDS service organization, check with your local health department, and maybe that would be a collaboration or partnership that y'all could do together in that regard.
This is Jessica in Alaska. That's kind of what we ended up having to do with our MSM screening events. Is the municipality of Anchorage Reproductive Health Clinic provided the space and some of the staff. We provided some more staff, and then our service organization provided more of the outreach staff. So they helped us, control the traffic flow, do a lot of the pre-advertising. So they still had a really important role in doing kind of these targeted screening events, but they weren't actually providing the actual STD testing.
Any other questions before we wrap up? Well, thank you all for joining us today for our webinar. Like I said, feel free to email me. My name is Stephen Hicks. I am the Health Equity and Capacity Building Manager at NCSD. My email is ncsddc.org. And I want to thank the Gay Men's Health Equity Work Group. I also want to thank NASDAD for their partnership with NCSD. And we wish you all well. Feel free to contact us for any follow-up. The webinar is recorded and should be posted within the next week. Thank you so much. Have a good day.